Good evening, everyone. I am Mrinal Madhav, National Program Coordinator of Site Service India. And on behalf of Vision 2020 India, RP Center AIMS, CBM, and Site Service India, I welcome you to this webinar on public-private partnership for primary eye care. We will run the session for an hour. Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. I'll take some time to introduce our resource person. Mr. Prasanna Kumar Narayanan, he is the Senior Director, Program Operations in Sightseers India. He looks after the overall implementation and growth of programs and strategic interventions in the country. He is a postgraduate in development economics and holds a master degree in development planning and management. He specializes in planning, implementation, and management of developmental programs with a deep understanding on various approaches for program development under child rights, disability, gender, safeguarding, livelihood, and eye care are his strong areas of expertise. Our next resource person would be Dr. Sarah Varghese. She is an ophthalmologist and public health specialist and the managing trustee of CBM India Trust. She earlier worked with the World Health Organization Southeast Asia Regional Office in the area of disability and rehabilitation. She previously served as president of the Vision 2020, the Right to Sight India, and played a key role in eye health planning for Vision 2020 in India, Nepal, and Bangladesh. Along with Dr. Sara, Mr. Ravi Ranganathan will be co-presenting. Mr. Ravi is a highly experienced development professional with over 20 years in this sector, currently serving as the Director of Programs at CBM India and part of senior leadership team. He leads inclusive health, education, livelihood, and environmental initiatives with a particular focus on inclusive eye health across India. Ravi has extensive experience in community-based humanitarian assistance, managing complex programs in collaboration with a network of NGO partners and government stakeholders. He has also played a vital role in overseeing the implementation of key initiatives in partnership with government and NGO-led eye hospitals, ensuring accessibility to healthcare for marginalized communities. Uh, our next resource person would be Dr. Praveen Vasist. He is the secretary on the board of Vision 2020 India, representing. He is a public representing Dr. RP Center AIMS. Dr. Praveen is the head of community ophthalmology at Dr. RP Center. He is a public health expert and postgraduate in community medicine from LHMC New Delhi and has completed his master's degree in community eye health from London School of Hygiene and Tropical Medicine, London. He has been instrumental in developing community outreach programs along with strengthening epidemiological research and training in the field of community eye care. He has contributed immensely towards development of health policies as key resource person for technical support for National Program for Control of Blindness in India. As a principal investigator, he has led all major surveys at national and state, including development of India Vision Atlas. He was member in several committees and received several awards. We are also thankful to Orbis Cybersite for providing us the Cybersite platform. We appreciate the support from our corporate advisory board members that include Appasamy Associates, Orolab, Asila Luxottica, Forus, and Microflow Devices for their continuous support. For the audiences, there is a Q&A box where you can type your questions during the session and we will answer them at the end of the presentation. Thank you once again for your participation. Now, I would request Mr. Prasanna Kumar, Dr. Sara Varghese, Mr. Ravi Nanganathan, and Dr. Praveen Vasist to take on. Thank you. Prasanna, sir, over to you.
And good afternoon, Dr. Praveen, Dr. Sarah, Ravi Nangan, and all my participants. Today, I'll be talking about our experience in one of the districts. So, this experience of Site Service India addressing the primary and district-based model, that is Ramgarh, and this is in partnership with the government of Jharkhand. Next slide. I'll talk about the location and the basic information. Then definitely talk about PEC, rural health and school health, program process, major investment, HR structure, impact, that is result till date, lessons learned and challenges. Next slide. So this is with the Ramgarh district. We have actually six blocks, headquarters in Ramgarh, population of 1 million, and 50 plus population is 177,000. So area, and there is also predominantly in scheduled caste and scheduled tribe population, that is around 35%. And next slide. Yeah. So in terms of the eye health facilities, we have three ophthalmologists there. That is all government, and around 10 ophthalmic assistant. Then district one hospital, district hospital. Then CSC is four, PSC five, and vision centers are 3+3. So ASHA workers are 1200. So basically, this is the infrastructure which we look at the district as a whole. Next slide. And again, we looked at the population, the blindness prevalence visual, that is 2.13, and which VI prevalence is around 14.12 percentage, and cataract blindness backlog is around 3084. Next slide. Okay, so our model is that Netravasan, that is REH's major activities include that primary eye screening, then refraction, awareness generation, volunteers creation, training, spectacle dispensing, and cataract surgery. This is basically in the rural eye health program. We call it as rural eye health program. Next slide. Yeah. Then the school IELTS project, that is Vidya Jyoti, there again we have primary screening, refraction, awareness, then SMC sensitization, teachers training, and spectacle dispensing. Next slide. Yeah. So what is the process which we look at? First thing which we do is that we engage with the government, that is NHM, Government of Jharkhand and Site Service India. This is applicable to all the states where we work. We engage with the team, the government, and also with the direct MOU is signed. Then, or before that, we do a district eye health facility assessment that we do regularly. In that district eye health facility assessment, we assess the capacity of taking up primary eye care as well as secondary eye care at the district level, and negotiations are taken from the government level. Then after that, we decide the process is that where are the PSCs, if there are vision centers available, is there a screening happening or everything is looked at. Then we decide on the key investment decision, that is locations and key investment decision, and also along with that, the vision building exercise is done for the district along with the government. Then planning meeting with the district team and the state program officer also is taken. And state program officer sometimes also invest a lot of time, as well as they also invest in the infrastructure development and training. Then identification of key strategic needs, that is equipment, human resource, community mobilization, and service delivery. This is majorly the process which we follow. Next one. Next slide. So this Ramgarh, what is the investment we did is that vision center equipment and integration of PEC into CSC. That is three community health centers has been fully equipped and made functional. Then clinical assessment of the operation theater and equipment and infrastructure also investment from site servers part. When we started, there was the OT has to be redone and rebuilt. OT equipments were given. Then human resource training, support to ophthalmic assistant, optometrist, and ophthalmologist. This training, also hand holding and discussions, and also has been done. Then community involvement is mainly with the PRIs, Panchayat Raj institution members, community volunteers, ASHA workers, and all. Then again screening camp and spectacle distribution of spectacle support. Then information education and communication materials, teacher training. Then one important thing is that we also for school eye health program we also have partnership with education and health department and RBSK. Next slide. And so, what is the human resource structure there? That is, we have SPO, CMHO, ACMHO, ophthalmologist, and ophthalmic assistants are there in the government sector. And with our side, we have district program coordinators, two, REH and SCH, then optometrist, two, and community health worker are two. These are the structure of health structure which we have there. Next. So if you look at what is the result now, for primary screening, we could 159,000 children have been screened in the school eye health, and then 157,000 people are screened at the rural eye health program. And secondary screening is 94,000, and the children are refracted are 5,000, and the elders refracted is 40,000, and spectacle 4,267, and spectacle distance 4,067. Cataract surgeries we have done around 6,324, and 629 children have been referred, and school covered 960. This is the key indicators. There are other indicators like school covered as well as the teachers train and ASHA workers train and all. Next slide. Okay. What is the impact? One of the block is declared as CBBF, cataract backlog blindness free is declared now. Then cataract surgical rate increase. Community volunteers, PRI members, ASHA workers started effectively engagement. Then functional PEC services in three locations with all screening as well as other aspects have been covered. Functional secondary service at district level with a provision of three ophthalmologists. Then six model schools created and eye care champions developed. Three blocks saturated in terms of screening. Referral network established. Effective partnership in education, health and RBSK. Next one. Next slide. And so lesson learned is that availability of skilled HR to be ensured, transfer always pose challenge. This is specifically in relation to the ophthalmologist. Then ASHA workers incentive is a issue. That incentive never comes on time or government is not paying that. Here currently we have picked up that in this thing and we are paying ASHA workers directly. Therefore, it is working. Engaging with PRI and community volunteers are important. Whenever there is a screening camp or any eye care program is happening at the village level, PRI members' involvement is a must in terms of their contribution, in terms of their organizing. Then maintaining the relationship with the state and district level officials by people like us is very important. And spectacle compliance among children and quality spectacle is an issue that has been sorted out by us. MOU with the government department is a must. Then no medicine support by private people. Private always prefer government sources. We never give through no medicine has been given from any private sources. All is referred, everything is given at the government level. And referral need to be addressed very carefully. Next slide. So these all are the some of the way which we are addressing the primary eye care mainly, and this is the partnership with the government of Jharkhand and site servers only. There is no other NGO, no other people. We are directly working with them, and now the secondary eye care level is fully functional. Government is Jharkhand government has allocated money for addressing the issues of DR, glaucoma, and other issues. This is it from my side. Thank you so much. Questions and anything is there which we can take up later.
So, thanks to Vision 2020 for inviting us to share our experience. I'll talk about, Ravi and I will talk briefly about some of our experience in the public-private partnership, uh, particularly for primary eye care. Um, and I will not talk a lot on primary eye care. I think all this audience knows the importance of primary eye care to address the large volume of eye care problems, which can be managed at the primary level without having to be referred to a specialist center. And having primary eye care and vision centers makes it both cost effective for the community, convenient for the community, that they can access services uh, close to their homes. And there's also a great need for low vision services as well. We again all are aware of the huge need for vision centers across the country. And even if we talk about one vision center for 100,000 people, in the rural areas itself, we need close to 10,000 vision centers, and we know that not all areas have access to this as yet. So there's a need to scale up the development of primary eye care and the development of vision centers. While CBM has a number of vision centers in association with NGO partners, I will talk mainly on the vision centers which are working along with state governments to provide primary eye care through the machinery of the state healthcare services. And there are currently 18 model vision centers functioning in public-private partnership model in different states of the country. I will highlight here what we are doing in Karnataka, Haryana, Sikkim. And while we are working with RP Center and Dr. Praveen through them with a number of all other aims, I will not focus much on this because perhaps Dr. Praveen might refer to this in his own presentation. So in the state of Karnataka, uh, it's not just about vision centers. While vision centers are happening in district hospitals, low vision centers are also being supported both in district hospitals and the Regional Institute of Ophthalmology in Minto Hospital. The vision centers we have working in primary health centers and one CHC. Besides these vision centers, there's also skill enhancement training, surgical skill enhancement training happening for government ophthalmologists, training of ASHA and other frontline workers for doorstep screening. School screening is happening and with spectacles for needy students, and training hospital staff in low vision care. This is happening in partnership both with the Department of Health and Family Welfare, Government of Karnataka, and the Regional Institute of Ophthalmology, Minto Hospital in Bangalore, which has also played a catalyzing role in initiating this program. In the state of Haryana, it is happening in 2 CHCs, and low vision services are established at the Regional Institute of Ophthalmology. In Sikkim, a number of different activities have happened, including conducting a gap analysis, strengthening district hospitals, again, building capacities of government doctors, sponsorship for paramedical training, establishing low vision services, and due to the terrain of Sikkim, establishing mobile eye care services, and vision centers were established under a separate project as well in the state of Sikkim. The importance of mentioning this differences from state to state is that every state is different. It depends on the investment of the state in healthcare, the way their health systems are structured, their population, the resources available in that particular state, and the availability of I- government services or NGO services. I'll just briefly touch on what's happening through Dr. Praveen's own unit. It started, of course, with initiation of low vision and disability inclusive eye care services at RP Center, but it went on to extend low vision services in other hospitals, Regional Institute of Ophthalmology, establishment of vision centers, both in regional institutes and in other aims, mobile eye care services, and along with this support for Ravi studies across in a number of locations across India. The Vision Center framework, CBM tends to have a two-staff model, which includes a vision technician and a community mobilizer. The standardized equipment is as per Vision 2020 guidelines. Spectacle dispensing happens. Then diagnostic equipment with because when the vision center is in this PPP model at a PHC or CHC, there's facilities for medical consultation for NCDs, communicable disease, and other diagnostic equipment available at the PHCs. In this vision center, in this model, the PHC CMO or the medical officer are part of the vision center management, and the frontline workers, ASHA workers, ANMs, Anganwadi workers play a key role in referral pathway systems. Ravi will talk briefly about the reach which has happened through Karnataka and Haryana, leaving the other two states.
Yeah. Thank you, Dr. Sarah. When we look at the number, we have just taken only the last three numbers because can you just go to the next slide? Just move. Yeah. Thank you. So we didn't take the long history of the statistics. We have taken the last 3 years. So what we have seen is that there's a very good amount of people who are coming to the vision center. In the PHC model, minimum 20 to 25 people are visiting. An average uh, 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 people visiting the vision center is 25. And in the CHC, it's about 40 to 45. That's an average number. So when I take this comparison with our NGO model with the vision center we are running, the minimum threshold is 10 to 15, which we are achieving. So I see that there is a lot of people who are coming to this model, and the screening is also taking place at the door to door. Also, the community health worker, the ASHA worker, all the frontline peoples will do the screening and referral to the PSC where the vision center is. Also, we are referring to the patient to the district hospital and to the RIO for cataract surgeries. One good thing is that the RIOs and district hospital, they come up with a package like very fixed date for surgery referral. So the people in the local community, they know that when the doctor from the RIO and the district hospital will come and they take them for surgery. We also did a lot of person with disability getting assistive devices, including the spectacles. In one district, we have done the piloting of ASHA worker. It's called ASHA Kirana program. We have covered more than 1,600 ASHA, and they are able to reach about 20,000 people in a month time. So that was good achievements. And overall, as on date, is 20 lakhs people were covered under the ASHA Kirana in northern Karnataka. Next slide.
Yep. So I'll just speak briefly on this. So some of the learnings we have found is that this has improved the access, particularly for persons with disabilities, to PHCs. The awareness created at the PHC has gone beyond just eye care treatment or eye care services to an awareness of the needs of persons with disabilities. As Ravi has already mentioned, the footfall in the PHC or CHC is very much higher than in those run by vision centers. The the vision technicians are trained at the Regional Institute of Ophthalmology and prior to posting in the Vision Center. The referral system to the district hospitals or regional institutes has been working reasonably well. We've also already mentioned the training of health workers, and that if free spectacles are available, this increases the uptake of services. I'll allude to this again a little bit later. And this addition of eye care to the primary healthcare system has been very much appreciated by all stakeholders. Some of the other good practices is that the vision centers have all been made wheelchair accessible. Um, we have been able to ensure adequate seating and adequate size of the rooms for the vision center. The intensive training at the RIO has been seen as a plus by uh, both the technicians and the doctors, the medical officers, and those in charge of the eye health program. They also work in partnership with local NGOs and community based organizations to increase their reach. Um, as I said, free spectacles have been made available with additional resources which were over and beyond what was initially envisaged. And school high training is also taking place. In addition to this, there's screening for diabetes and hypertension um, happening at the P. There's standard protocols. Patient satisfaction assessments have been happening and data-driven decisions. And the particularly in the government in Karnataka, the monitoring is not just by the CBM, but by the state steering committee, the district blindness control committee, or the district blindness officer. And there's also additional monitoring by the regional institutes of ophthalmology. Ravi, over to you.
Yeah, thank you, ma'am. So I would like to very precisely mention the impact. So when I recall 4 years back, the RIO, we just had a tripartite agreement with the public health department, RIO and CBM. There was only very few uh, ophthalmic officers were in the health system. I remember about less than 20 people in the whole state. So when we started, I feel that it's a good kind of it has impacted that today. This is the last week update when we were working with the government. We got the update. The government has recruited 346 paramedical ophthalmic officers. This is a very good indicator that how the system strengthening approach work, particularly integrating the eye care into the health system. So 346 people are already there, and then the government is already in a plan to recruit additional 75 people. Even they have interim plan that the 75 people PMOs shortage, which is also managed by the RBSK optometrist. So I see the kind of good move and the kind of good system is already driven there. That is Karnataka. Going to Haryana, next slide. So Haryana is though it's a very small program, but it also has created a multiplier impact. What we did first, we started one center. Then the second center, they said they don't want a human resource. They just CVM can only give the equipments. We'll bring the human resource. The government brought the vision technician, the community mobilizer. And the another good news that the first vision technician in Rohtak, she moved to a government cadre now. She applied to the government job. She's working in the one of the vision center, which is supported by CV. So it's a kind of initiative taken by the government that the sustainable measures are already in place. The person to run the vision center. We also see the RIO directly monitoring, and they are very actively involving in the day-to-day operations of the vision center. Then I move on to the AIMS model. Dr. Praveen is here. I'm not going to share much because
Okay, please speak, please speak.
he can share what is the impact. But I just recall that we have 11 vision center. I got an opportunity to visit few RIOs. I see that the vision center, the low vision, which are the new annexes to the RIO programs. So the vision centers are already functioning, and as we recall, it's almost about 10 years now. The first meeting Dr. Praveen has organized for the entire RIOs, about 16 RIOs. The members participated, and then it's a collaborative efforts with CBM and RP Center. We have conducted training to the RIOs. As a result of it, many RIOs came forward directly. Even the government has given the guide kind of circular saying that if anything on low vision, you can approach CBM. So that's kind of appreciation as a we need really thank RP Center for bridging that platform for RIOs. And then the first RIO we started working with Bangalore. Then we already see that the kind of good partnership and impact is already there. Accessibility, making accessible features. Also, we got a collaboration for various studies with the RP Center. Then to the last model is the project Ujalo in Sikkim. Here also I need to really appreciate Dr. Praveen for initial the gap assessment. He was part of it. I recall a few years back he was there. The gap assessment was done. The good thing is that in this one state where I'm not sure Dr. Rajesh is there in this session attending. He is the one who's actually monitoring the projects. I see the line department, the district officials, more than 40 departments are collectively working on addressing the eye care. For example, the health and education working together for the school screening program. I heard that there are funding allocation between the departments for eye care if needed. The various resources, infrastructures were used effectively for primary eye care. Also, the doctors in the general hospitals, more than 200 people were trained. I see the very good impact which is on going on. Yeah. So over to you, ma'am. So I just stop it here.
Not everything is very smooth. One of the biggest issues is signing an MOU with the government, which goes up and down through various departments and takes a long time. Initially, there was no human resources available, and the allocation process to get space at a PHCs can also take a long time. One of the biggest challenges was spectacles, because being located in the PHC, the sale of spectacles was difficult, could not be done. And this, of course, affects the financial sustainability if you look at it. However, if you look at it in the other way, as the government is increasingly taking over the staff and employing them on their roles, there is sustainability of human resources. And we have got around this by raising other funds from CSR, particularly for free spectacles for those who need it. There are still challenges. There's, if I can say, um, the competitors, the spectacles shops outside are the first people to complain because they feel their sustainability is going down. Another constraint was possibly the limited number of surgeries which could be taken up by the RIO in Karnataka. And this has been addressed by also roping in and training district hospital doctors. The staff can be also quite overstretched. So there is definitely scope for further strengthening, and Ravi will explain, suggest what can be done.
Yeah. So looking at the time, I just rush quickly. So there is definitely scope for strengthening the eye care, bringing more value addition. I have seen in Karnataka there is already a system is there for teleconsultation. So maybe the RIOs and other institution they can try to keep the doctor on roster or particular day for teleconsultation. DR mobile unit or DR screening at the vision center can be added, and then training of all government vision technician on a comprehensive screening at RIOs will help. And scaling of vision center and other CAC and PACs also it's very important because they already got the manpower and everything. Next slide. So I request Dr. Sarah to conclude. I just hope.
Yeah. So, in summary, this is a very effective model. We would like to scale it up. We also need longer term CSR investment for sustained impact. Um, we it's important to engage both regional institutes and other hospitals, including sometimes NGO hospitals, which can be challenging if the vision center is in a government setup, because referring to an NGO hospital may not always be possible. Um, it's important to collaborate, to network, and it's important to think of the long-term sustainability of which uh, the Karnataka model of increasing the human resources is excellent, but also the Karnataka state networks supported by Vision 2020 is an excellent example of how it can be made more sustainable. Thank you. And apologies if it took too long.
Thank you, Manal. In fact, you have seen two very good presentation. One by site savers, where we can definitely see that they have presented model of a district where they have initiated primary eye care services, including the secondary level service in that area. And of course, the CBM model, which is probably the nation-wise model, and so many activities covering various model, including North India, Delhi, Haryana, in Sikkim, in Karnataka. This is fantastic, and presentation was extensive. Probably that's all my purpose. I can just restrict myself to very specific point which I would like to share our model that RP Center is doing. We know that the requirement of vision center country is around 20,000. That was kept as a target of 2020. And even now we have hardly around 4,000, maybe 4,500 vision centers in the country. What is the reason why vision centers are not there? Probably when we say that why people want to actually different institute want to start primary eye care services, the reason what I feel is it's only the NGO hospital, they initiate the services, and their key aim is to create awareness about the base hospital, that this hospital exists, services available, people should know about the hospital and utilize their services. They want to increase OPD and also surgeries in the base hospital. And of course, sustainability through spectacles. But if we see all these points are not valid for government hospital. Government hospital, I rarely see any government institute in public sector. They are involved in primary eye care services. In fact, if you see RP Center, I get so much of, kind of reaction. Why do you want to start primary eye care services when the hospital is already so much overburdened? We are even giving cataract surgery date for 2 months in the hospital. If you go for specialized surgeries, even up to 1 year date is given. And we see more than, say, 5.5 lakh patient per year in the institute. In spite of this, the community ophthalmic section, we decided that we'll definitely have our primary eye care program, and we should have our vision center also. The purpose is not to increase the number of surgeries or number of patients. The key purpose is to actually eliminate avoidable blindness and visual impairment in the catchment areas. And of course, a kind of operational research to develop unique models for primary eye care services. And of course, we wanted to reduce the burden in the hospital so that people who need services can be tackled at primary level, especially the refraction cases. They should be dealt at primary level only. You are shocked to know that nearly 43% of the OPD in RP Center, we are the apex institute of healthcare in eye care in India. Nearly 43% are refractive error cases. We can reduce those cases if we have a very, very prompt, good primary eye care system. So I need to discuss various models which are there, which we are running actually. They're into four groups. One is, of course, the starting services with the daily government dispensaries. It is an integrated model for primary eye care. Second is involving local NGO or the CSR funding, uh, like providing ownership to these local NGOs. That is second model. Third is, of course, I thankful to CBM for this thing, that a model which can be adopted with other government institute, with other aims and RIO. So a kind of mentoring these institute for primary eye care services. And last, but probably the most important, is the ASHA worker involvement, the community level worker involvement, so that we can have awareness and some services available in the community. In fact, the model one is integrated model with Delhi government. I believe this is probably the most cost-effective model which we can think of. Vision centers are kept in population which are vulnerable, where services are not available for eye care. And one indicator which is used by us is the ASHA worker should be available. If ASHA workers are there, then those areas in Delhi are considered as vulnerable population. So we have partnership with Delhi government, and it's a part of the comprehensive healthcare delivery dispensaries. So that means patient is not an issue. We have sufficient patient. The footfall is already there of those patients. So whoso require eye care services, they are being given eye care services. Infrastructure is provided totally free of cost by Delhi government in their dispensaries. Medical office. This is very important. Optometrists are not allowed to prescribe medicines. Here we have medical officers available. So if any medicine need to be prescribed, that is being prescribed by these medical officers. The supportive staff in terms of ANMs, ASHA worker, and other volunteers is already available in these dispensaries. Medicine is available free of cost in government dispensaries. And spectacles, sometimes they provide it free of cost, sometimes we arrange through different resources, but ultimately we are providing spectacles free of cost in daily government dispensaries. I believe this is wonderful cost-effective model, and government of India also promote this model. I believe the the NGO hospitals, the standalone eye care hospitals, may be finding difficulty in running such kind of integrated model in their areas. The second model is, I'm talking about the local NGOs. We have partnership with the Dipalya Swami Shivanand Memorial Institute. DJJS is one agency, and also Hero Motors. The patient mobilization is the responsibility of these local NGOs. They have been given ownership of the vision centers. We are the visiting doctors or optometrists in these centers. And these NGOs also provide free infrastructure. Their NGO volunteers are being trained and doing like patient mobilization. Spectacles are provided at subsidized cost for 200 rupees or 250 rupees, depending on type of spectacles. Medicines are being provided from various projects from RP Center, and referral of all these patients, whether it's a government institutes, vision centers, or NGO on vision centers. Refer is done to RP Center for cataract and other surgeries. The best part is that these NGOs, they ensure transport facilities for patient to and from RP Center. So those patients were to be operated. What RP Center is doing with the support from various INGOs, whether it is Mission for Vision, CBM, Sight Savers, or Vision Spring, we are hiring team which is part of the project. It is optometrists and field workers, field investigators. They are posted. One team is going once in a week, and depending if the requirement is more, we are even sending more frequently. Usually they're covering a population around 2 lakh. One team covering population of 2 lakh. So if they're giving 5 or 6 days in a week, so around 30,000-40,000 each area is being covered, but they're going in different locations. This is the number. This is probably the most important thing which you can learn, that we have OPD from 40 to up to 120 patients per day. This is huge. I've never seen in NGO sector, other places, such large number of patients coming for primary eye care services and refractions. Monitoring is very strong, record maintenance, daily reporting is there, proper supervision is there, and we have software-based data entry, plus, of course, the referral to base hospitals. The third model which I would like to discuss is again the Project Roshni model. Then Sarah and Ravi also have informed. We have, like, it is running in Delhi as well as in 2 RIOs and 2 AIMS in country, AIMS Bhubaneswar, AIMS Jodhpur, RIO Patna, and RIO Amritsar. I was very doubtful actually when we took initiative for providing low vision and primary eye care services. I was worried whether they will implement it or not. But I'm very happy and satisfied to say that after proper training And of course, monitoring, we are getting a very good feedback. Though the number is not as high as which is there in Delhi, but in all the centers, low vision clinic and primary eye care clinic are being managed, run, and it is being monitored centrally by RP center. In fact, this is the number which we are very happy to share. This is last 1 year data. In 1 year, we had a target of 100,000 patients to be seen, and we got it 104,000. See, it's achieved the target. Through just this project Roshni alone, we got more than 1 lakh patients seen in one day. Of course, refraction services, spectacles, there are around 18 indicators are there. I believe most of the indicators are being very well fulfilled. And this number is, our total annual report. This is 2024. The community ophthalmology services, they covered 1,75,000 patients. And out of this 1,04,000 is just of this project Roshni from CBM. I believe 2/3 of our services through this one project alone. What we are doing is we are providing primary clinic in terms of reflection, training of ASHA workers, volunteers, health educations, and referrals. Plus, diabetic retinopathy is integral part of this thing. We use this Vox Pictor or AI-based cameras for DR screening. Glaucoma screening is also now a part of this thing. Intraocular pressure is being done. Photographs are being taken. School vision screening is part of primary eye care. And of course, this covering school for blind, providing them disability certification, low vision rehabilitation services is also integral part of this primary eye care. I believe if I wish to invite you in one of our vision center in Trilokpuri, we have all the state-of-the-art equipment, whether it is slit lamp, whether it is portable fundus camera, if it is indirect ophthalmoscope, portable non-contact tonometers, all these equipments are along with the routine equipment in this vision center. And data management. This is probably the perfect thing, totally available free of cost. That is online data kit platform. And all the data, whether it is vision center or cataract surgery, everything is maintained in this ODK platform. It is just an app actually, which one person has to screen it. Then data entry can be done on mobile phone, and entire data can be uploaded in our server. We have a dedicated server in AIMS for entire data. And of course, this data is analyzed in the software itself, and report is being shared on daily basis at around 4:30 p.m. Every day we are sharing the report with all our optometrists and team members. This is probably one of the best way of monitoring the entire program. Whether it is in Delhi, whether it is in Jodhpur, whether it is in Bhubaneswar, everywhere, every evening we are sharing the daily report with our partners or something. And when one stroke of button, we can actually analyze what are the ocular morbidity profile. The refractive error is around 34%, cataract is 14%. So we can get such kind of data within a minute time actually using this software. A plus, of course, health education is important. With the help of CBM, we have developed eye health education material for all the diseases, and this material is posted somewhere. Daily health talk is being given in all these vision centers in the morning by our team members. Of course, now coming to the fourth model where we are looking forward, if we really need to strengthen the primary eye care system, that means we have to work at the community level for ASHA workers, Anganwadi workers, or school teachers for school vision screening program. So this is one initiative about training of ASHA workers that we have taken, and I feel very happy and satisfied. In fact, I had suggested an integrated people-centered eye care approach. That means we have to engage and empower the people in people and communities. So ASHA workers are being involved. This ASHA worker, in fact, before 2005, ASHA workers were not there at all. And now we have nearly 1 million ASHA workers in the country. Previously, they were involved in other programs, mainly maternal child health program, tuberculosis program. We took the initiative in 2010 and motivated government that they can also be involved in primary eye care services as a link worker between community and vision centers. In fact, we adopted a one-day training program and implemented it entire Delhi with the help of the health secretary in Delhi. That one-day training program should be initiated for all ASHA workers for primary eye care. And in this training program, what as an outcome, what they're supposed to do, they are supposed to do the vision screening in 40 plus population. Initially, we thought of having two different cutoffs, 6 by 60, 6 by 18, but it was a learning experience that single cutoff of 6 by 18 should be sufficient for screening of ASHA workers. Cataract surgery, if you see, there's so many barriers are there for cataract surgery. These are barriers we got from our national survey. And what we realized that all these barriers can easily be tackled by ASHA worker who are available in the community, except one barrier where some contraindications are there. Rest other barriers can easily be managed by ASHA workers. ASHA workers are helping us in increasing the follow-up of operated patient, cataract patient. This is so important. I believe they should be implemented all over the country using ASHA worker to improve the follow-up cataract patient. Presbyopia, now WHO include presbyopia as one of the cause of visual impairment. We did national survey, we realized that only 25% is the coverage for presbyopia in our country in 50 plus population. That means 75% people who require spectacles, presbyopic spectacles, they are not using it. Who can do it? ASHA worker. They just have to refer the symptomatic patient with near vision problem to vision center, and definitely we can get a very good coverage of presbyopia with the help of ASHA worker. Even for diabetic retinopathy, they just have to identify the diabetic patient and refer them to base hospital for eye examination. Again, in national survey, we found that only 10% of the diabetic, they are actually got their fundus examination done, only 10% of diabetic. If ASHA worker can request all the diabetics to go for their eye examination, that will solve our purpose. We can utilize them in this manner. Of course, they are being very well used in vitamin A supplementation in immunizations. They can also be used in checking the expiry date of medicine, cleaning of eye, etc. These are the various options for ASHA worker, which we involve them in such kind of training or something. And I believe for awareness generation, for presbyopia management, for vitamin A prophylaxis, and for referral services, they are +4. They can be very well used into the program. This is my sincere request. If there are any use of this webinar, I request all the agencies to utilize these ASHA workers for strengthening primary eye care services in their areas. The best part here is that the incentives for cataract surgery and for spectacles are being given by Delhi government through their National Health Mission Fund. This is the major advantage with us. I believe even Sight Savers is not able to do it. They are paying through their own resources. But we are getting it given through the Delhi government through their National Health Mission funds. I think, and this is one module which we have developed for ASHA workers for Government of India, where training manual has been advised for ASHA worker. I am thankful to Dr. Promila Gupta. She took this initiative, and now this is a module available for the entire country where we can train ASHA worker for strengthening primary eye care services. I think this is the thing which I wish to tell. We have already trained more than 4,000 primary eye care workers. So this is the real community work achievement for us, that we have actually strengthened the primary eye care in Delhi and NCR region by training these workers. I think I should finish it now. Thank you. If there are any questions are there related to challenges, lesson learned, I would be happy to answer those questions from the team members. Thank you very much. Thank you.
Thank you all for attending today's webinar. And we appreciate your time, engagement, and thoughtful participation. Special thanks to our speakers for sharing their expertise. We also thank our CAB members for their support.
See you.
Thank you.
Thank
Thank
you.
you. Bye.
Thank you,
Bye.
everyone.
Thank you so much. Thank you for the fantastic lecture, Sarah and Ravi and Prasanna.
Thank you.
Thank you so much.